Yeah, hello and welcome to Wimpole Street Dental Clinic. My name is Christian Mill, and in the following small presentation, we would like to show you one of our cases of the month here made in our clinic. So, thank you very much for watching, and we hope you enjoy the video.
Yeah, hello and welcome back to the case of the month for September. I apologized for the past 2 months, but we had a very beautiful summer in Munich and in London, so I spent most of my time outside or in pubs. So we're back now, and as always, thanks very much to Martha Orban, who provide the dental technician work for this case and for both cases. And today I'd like to show you two cases where we try to improve the aesthetics of missing front teeth with connective tissue grafts. And let's go immediately to the first case. First case, you see what you always have when patients, especially female patients, have problems with front teeth. They don't like to smile in a natural way. They're very conscious of their appearance, and when we ask them to smile, they always feel tense and or put their hands in front of the teeth. And only after a while, when you assure them you will not make fun of them, then you get them to smile properly, like in this case, and you have a feeling already that something's not right, and that feeling is verified when we have the intraoral picture. It's not a very beautiful situation. The tooth central incisors are not symmetrical. Then, of course, the tooth 1, 2, the upper right lateral incisor is way too high up. The ceramics are actually okay, but the situation as well is not brushable, it's not cleansable, so understandable that the patient is very unhappy with the situation. So what can we do? We have a big deficiency of soft tissue on the buccal aspect of the situation, and of course the gum line can not only be corrected with connective tissue grafts, but we have to use orthodontics as well to get especially the lateral incisor in line, and of course we have to get them down maybe 4, 5, 6 millimeters, and that could potentially threaten the vitality of the nerve. So we have to discuss with the patient all the options we have. She was scared of implants, didn't want to have any implants, and of course when we have a bridge already and we have the tools at our disposal to make the situation, if not perfect, but better, we can use those tools to make her life better. And as I said, implants were out of the equation, so we were stuck with conventional prosthodontics. First step is always take the old bridge off, get the central incisor symmetrical, see where the volume deficiency is, and this is after the first augmentation already. We see we still have a little problem with the oral hygiene, that's why we lost the papillas a little bit, and we still have a volume missing, so we went again for the palate, get a second transplant. Unfortunately, she had teeth until all wisdom teeth, otherwise he would have taken the connective tissue graft from the wisdom tooth area, which provides absolutely fantastic tissue. But in this case it was not possible, and we had to use connective tissue graft from the palate, which always contains more fat and resorbs more. After we've done the connective tissue graft, we did the orthodontics and tried to get the lateral incisor back in position. We still see after the first connective tissue graft that we still have a volume deficiency buccally, so we decided to go for a second transplant. Would have liked to place bone here, artificial bone or block graft, but that's what the patient didn't want. So after the second graft, 3 months later, we took the impression. Here you see the model of the situation. We always take digital impressions with the 3-shape Trios scanner and have our models printed by a professional printing company who also produce hard valves, and their models are really beautiful. And as you can see here, excellent for a technician because you still have the gum situation, can take out the dies, and very easy for the technician to work with. Then here you have The final prosthodontics, we used zirconium dioxide as a framework, and the palatal aspect was fully anatomical, only colored, and only the buccal aspect was veneered with feldspathic ceramic. And you can see that here in the picture from behind, the black dot on the lateral incisors is a spot where we are exactly at 1 millimeter minimum thickness. So that would be a spot where I should not adjust the bite if necessary. Then we prepared the teeth. We always give an injection and place a 000 retraction cord, clean the teeth with pumice and disinfect them again, and we place the bridge with Relix Unisym. Yeah, and you can see we still have a vertical discrepancy of tooth 1-1 to tooth 2-1. So, and of course the gum line of tooth 1-2 to 2-2 is still 3-4 millimeters too far up. But to extract the tooth any further would have meant that we would have to devitalize the tooth and perform a root canal treatment, and that's what the patient didn't want. So we had to solve the situation prosthetically, and that's exactly what we did. You can see her smile's all very more relaxed. What I don't like about the situation, I think that the incisal edge of the tooth 2-1 and 2-2 are still slightly too long. As they touch the lip, you can see that here, that's the best proof that they're too long, but the patient liked it like this, and you can always take something away. But I would have, and I suggested her that as well, to remove something, but she liked it as it was. Here the situation again, and patient is comfortable laughing, and you can't really see that the situation is not perfect. The gum color we chose blends in quite nicely with the existing gums. The ceramic is solid work, and when we go into detail, this is a final bridge then from lateral incisor to lateral incisor, and color of the gums is acceptable, and the color of the ceramic as well. Gum situation is okay, clean, and we left a small hole between the two central incisors, so she could go in between there with superfloss and brush properly. Patient was happy with that, but of course it's still a compromised situation. How we can do it better when we have better grafts is shown in this case now. See again, patient really doesn't like to smile. It's a labored smile. She is not used to really laugh wholeheartedly. And even at the end of the presentation, you'll see we could not change that. It will take some time to get used to. And then if we retract the lips, we see the reason why. Of course, to produce a bridge like this is making patients thoroughly unhappy. The two central incisors are just completely asymmetrical. Gum line is horrific, and the lateral incisor has a buccal deficiency, which is not as bad, and only the canine is in position and shape more or less okay. So same here, we need temporary orthodontics and a connective tissue graft, and that's exactly what we did. Orthodontics first. You see here, not a perfect situation, especially with respect to the oral hygiene, but a lot of patients are scared to brush temporaries for whatever reason, maybe to destroy them, but this temporary was of course cemented permanently. We separated the teeth 2-3 and 2-2 so that the orthodontics could extract or not extract, could move the central left incisor down. And we still have a deficiency, but the patient didn't want to continue with the orthodontics, and the orthodontist didn't want to continue the orthodontist, so we said, all right, we have to try to correct that with a soft tissue graft, and in this case, she only had up to the second molar, she had the teeth, so we had the chance to remove the connective tissue from the wisdom tooth region, sorry. So what we did is a Zucchelli technique known worldwide, I think by now. So that means you undermine the gums, produce a split flap without actually lifting the gums to not interrupt the blood supply. And then you just push the gum, the connective tissue graft inside this envelope and thus increase the volume and the vertical height. That's exactly what we did. And you can see the flexibility of the split flap. Put the transplant in, stitch it back together, and this is how it looks like 3 months later. And you can see we have another problem now. Instead of having too little, we have too much, but that's not to worry. We gave the patient ejection, corrected the gum line with 15C scalpel, and reduced the volume buccally with a rough diamond. It looks horrible, as you can see here, but it's not very painful for the patient, as the gums keratinize within 2-3 days again, and this is the situation after 4 days. So you see it's absolutely perfect again, and yeah, ready for the impression, which we've taken then. First, of course, we always take the color with the flash, with the side flash, and then with the polarization filter as well. So the technician sees the warmth of the body and can really determine which is the basic color of that tooth. Here again for the technician overview, so you can see all the cracks and so on. Unfortunately, we see the calculus and tartar here as well. So time for the patient to go to dental hygiene again. And although we've given the patient so many beautiful information, the bridge comes back with a color, of course, not right. The shape is not too bad, but the tooth 2 was too short for the patient. She wanted to have it exactly the shape like the right lateral incisor, and the canine is too bulbous and should be adjusted to the falling teeth 2-4 and 2-5 from the buccal aspect. Again, with the bridge inserted, we take the color, take a picture from the side, and take a picture with the polarization filter. And then we're ready to place a bridge. I think you'll agree that we have a beautiful gum situation, stable, healthy, no inflammation, acceptable papillas, and then we can place the bridge. That's what we did. We placed the bridge with Relix Unisum. This is the bridge in place directly after placement. I always, out of interest, I take a picture with the polarization filter, and we could get better with regards to cracks and translucency. That's very difficult for the technician because we chose a high stability zirconium dioxide framework with a flexible strength of 1400 megapascal. So the translucent aspect can only be achieved when we use a more translucent framework, which then in turn has, of course, the risk of breaking, or higher risk of breaking. Good. If we then have the shadow from the lip, this is 2 weeks after placement in the review session. We can see that the color is pretty good. The patient was absolutely happy. Shape of the teeth was good. And if we have an intraoral look, the gum situation adjusted now, and you barely can see that we have a bridge here. So the patient been very happy with the situation, and of course we've been happy as well. The color is not perfect, a little bit gray, but that's always due to the flash of the camera as well. It sometimes does not reflect reality, but as you've seen in the picture before, we got quite close. Yeah, thank you very, very much for your kind attention. Here the picture from the side again. Thanks again for your kind attention, and have a lovely month, and see you soon again. Thank you very much. Bye bye.